There's an underlying problem in medicine where people stay where they're unhappy too long.
The hospital administrators are imbeciles. I think that you're going to outperform every one of them in every department you can.
As long as groups and hospitals say you're only worth what your professional income is, not what you're bringing to the system, this is not going to be tenable.
If you don't have a good denial management person, 20% of your claims are going to go unpaid. That is a lot of money.
Clinical practice for surgery and procedures is something you have to spend day and night working on. It takes a lifetime to still build your own clinical practice. If we just understand the language of how you're bringing more money and what you need for it, then suddenly the discussions can start being had.
My 3As are anarchy, alcohol, assholeness.
Yeah, that sounds about right.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
All right, man. We are on a roll here in Chicago, Illinois. Whoop, whoop.
Someone's
Home of the
hometown,
Chicago Bulls
home of the great Kumar.
and the Bears.
You're doing all the work for me.
Kumar, this is not your first rodeo with us, brother.
Not at all.
Welcome,
Returning champ.
welcome back.
Thank you for the invitation again.
Welcome
It's
back.
always a great time, and I don't know what we're getting into.
What, me neither.
First question.
Softball coming.
Yeah. How long until AI
Uh,
takes
If
away your
I
job,
pull
Kumar?
Pornhub
Yeah.
on your phone, what is the number
Oh,
one
that's
thing
not-
you search for? No. All right. So, hey, we were talking offline, guys, and for all you out there, we don't necessarily have these extended prep sessions of any sort, and so we usually, we usually connect and we say, well, what do we want to talk about? And one thing that I don't know if you guys noticed lately, but the Society of Vascular Surgery voted against having an independent board.
Tell me how you feel about that, Miko.
I think it sucks. I think it's dumb. I think that we are a very unique specialty. I think that we are a specialty that could be directing ourselves into how we go about the future of our specialty. I don't think that we need to be tied to to surgery, to the American Board of Surgery. And even though there's a few perks and some financial perks, it is not absolute freedom. And when I say freedom, it's freedom to decide where the future should go, freedom to decide what the curriculum should be, how to invest our own marketing, how to direct the survival and the evolution of the specialty. Anyway, there's multiple things, and I'll invite your memory probably, Lucas, to the conversation we had with Dr. Frank Veith. That was one of his biggest fights that he lost. He said, I lost a lot of friends when I was very, very verbal about vascular surgery needing to be independent, needing to be a board that was not subject to anybody else's.
How long ago was that fight? When he started that fight? Was it many years ago, decades ago?
This fight with Frank goes back probably 30 years. It was probably around the time. He's got this really cool book called The Medical Jungle.
Mm-hmm.
If none of you or any of you haven't read it, get it as an audiobook. It's really cool.
It's a really good audiobook.
It's a good audiobook.
it's a good audiobook,
to get when you're driving. Anyway, he goes there through, when the endovascular revolution came around, he realized that this specialty was going to change. That was part of why the symposium was initiated to begin with, was that there was an absolute need to give ourselves an identity. And if you think about today, in many ways, vascular surgeons have an identity crisis in the hospitals. Administration doesn't even know what we do. Our valuation within the hospitals are not great. You go out on the streets and maybe some people think we do veins. And anyway, there's just a lot of other things.
I just want to not interrupt you, but make sure
yeah,
you know
please.
that that's actually the exact mirror similarities we all have in ours. Same exact bullet points of issues. It's actually not germane just about surgery. It's actually germane to exactly what our gung-ho interventional IR people actually feel too. Same exact thing. So you're not alone.
Well, yeah. Well, and I guess that was the preface to maybe having a deeper dive. Cross-pollination allows you to polish your thought process, and I would welcome to understand this particular problem through your lens today, and maybe we can dive into what that means, because you hit it on the head here, which is we're not that far from each other, in the sense that you're trying to fight for an identity and an independence, while potentially there's other people confabulating that. And I still don't really understand what the perks are, or why people may be so stubborn in the understanding or the idea. I mean, urology has an independent board.
Mhm.
Neurosurgery has an independent board. So there's other people that have realized this and have understood that we are very unique and very different, and maybe the path of having like-minded people in our leadership will dictate a better future for us than having boards that have members that are not adding anything to the top of the line. But anyway, and so I guess with that in mind, we can dive into, how about we start from some weird esoterical place and say what is at the core of the definition of what an interventional radiologist is. Not just the guy that puts a catheter, right?
Yeah.
But what is an IR in the heart, this philosophy of care, and potentially why is that maybe so different than what an imaging radiologist may be.
What's interesting, you go back, I mean, it's hard to unwrap all of it, but when you go back to where it started from a diagnostic radiologist, which it wasn't necessarily separated to diagnostic at that time. It was just a radiologist started tinkering with a procedure based on the x-rays, right? When daughter did the first endo SFA, it was kind of like, hey, maybe we can apply what we see here day to day and then now become mechanical with it. And I think the problem for the last 60, 70 years has been, how do you separate the radiologist into two sections, even though you primarily are trained by radiology into imaging? And then you have this subset who now is a proceduralist who's based on imaging. So over the years now, we've seen multiple specialties adopt those practices and hone those skills and develop new things from what was primarily originally a radiologist starting to stuff. And cardiology blew up. That's surgery, endovascular. Now you have interventional GI, which it's taken us 60 years to get identity. They got that name IGI in the hospital within 2 weeks. I don't know how they figured that out, but I see consults and I was like, IGI. I'm like, where did this come from? We've tried to figure out our name for 60 years. So I think the dilemma has been, for radiology, you are pretty much still under radiology, which their primary role and purpose is to develop imaging, develop diagnoses based on imaging, and research and imaging. And then you have what people like to say, the line monkeys or the plumbers within radiology, who are the ones who want to do procedures. Now, historically, in many practices, that's biopsies, drains, line placements, this and that. But over the decades, the innovations in dialysis care, in peripheral arterial disease and venous disease, and now into MSK and all these things, that's blown up. But the problem is, we don't have a large section within radiology that's clinically based, managing patients as their primary role. It's a hybrid of do imaging and do procedures. Now, what happens with that is we have to always follow the money, right? What is the money supporting your income, your hospital giving you things, right? It comes from, well, what are you bringing in? So here's the dilemma. We all are we're kind of we're the meeting called AMP. We do complex arterial venous disease. So you guys have helped pioneer all together, all of us, a DVA or a complex tibiopetal. That 2-hour case, the professional fee, which a lot of trainees aren't taught this, which is why at the course I run, we try to make them understand these things. The hospital and your groups and stuff will see your professional fee. They are not seeing the technical fee, which goes to the hospital if you're in a hospital system. So the technical fee that they charge insurance or whatever could be, let's say, $20,000, $30,000, whatever they get is different. My professional fee that I'm technically given is $700.
Yeah.
So in that 2-hour time period, I brought into my group $700. At the same time, I could have read probably 52 MRIs and made $20,000 of revenue for the group. So this is the dilemma, because when you have a group that has financial variability in what they bring in, there's always going to develop problems. And as more medicine has become a business, and you have administrators and you have managers, they're going to say, wait, why are you doing that? And the rest of your group is building this, and we have to now support you in the group. So this creates an impasse, right? How can I spend my time developing a clinical practice, seeing patients, doing complex procedures, dealing with the complications. Meanwhile, my rest of my partners who have to go off the same bonus are technically supporting me. So this duality does not seem to exist if we want to be a clinically relevant specialty, which is why IR has become an independent residency, but it's integrated. Just like I think vascular surgery has the 5+1 or whatever. So it's moved on now in the last 7-10 years where you go from medical school and you match it to integrated IR. So it's not, you go into radiology, which is what I did, and then 1-year fellowship, and now you can get subspecialized. It's, you come in from med school and you're 6 years in the program, but you get dual certified. Now that's one step better, because now you're getting students who are eager as hell in med school. They love this specialty and they want to come in. They just have to get through the extra years of radiology, which is just how the system is. But that's the stepping stone in my mind. The only way to get true clinically relevant IR trainees who go out there and build practices is do their training in that space. And so I think we're getting at this point where we have to learn how to separately exist or separate. And the separately exist doesn't seem to work when money's involved.
I've noticed a few posts of people hanging their lid up because they were passionate about it. They become radiologists. Then they're in a hospital system where there is a lot of abuse. To your point, I mean, I remember very vividly where in order to get a particular port or something, you would put an order, and that order would essentially pop up in the IR suite. And then the IR guy gave me a earful of it because I never really consulted him how it should have been, really. But I put an order, and the thing is, I had to put that order in. So ultimately, he was under the scrutiny of an order. He didn't like how that was working, and he probably, took the intern and just blasted my ass for a more systemic problem. But, when the financial aspect is in misalignment, and then the professionalism and the respect of a specialty is in misalignment, then what happens with these folks that have done radiology to begin with, then they're like, why am I doing this? Why should I not go to my offsite spot in Costa Rica,
It's a very specific.
very specific place to go.
log in, or, Tulum, call it whatever you want to call it. But they work remote, and they read remote, and they can read a lot more, a lot quicker, without exposure, without the hospital bullshit, and make more money. And so,
But this is the problem. There's a plan B. And I think for us to build what we've been trying to build from a clinical specialty that's relevant and recognize, you can't have a part-time procedural clinician. It just cannot exist, because if you always in your mind have, well, I'll do this until I can, and then I'm going to take it easy and go do locums and read from Costa Rica, you're never going to fight to build what you have to. Like as a surgeon, you guys have to go, and it's not brick and mortar, but you still have to hang a shingle and put your name out there and start building.
Yeah.
Right? If you don't, the other option is retire or go do, industry or something else. It's not, I'll do another part of my specialty. That really is not relevant. You still need to operate or do procedures. In ours, it's like, okay, I'll actually go make more money and do no more procedures and just, have coffee in the morning and go home. And I'm not downplaying radiology because that's a critical field, but it's not like I'm just going to tweak what I do. I'm going to completely do the opposite of what I do. So as long as you have an option, most everybody as human nature will always be like, if it doesn't work out, I'm cool.
Yeah.
And that is not how your specialty survives.
Why wouldn't it be that you do both, and then that way you distribute the economic risk?
Until you can figure out how to make your value the same as the other person doing the same hours of work, it's never going to be. Whether you're in academics, and it's actually more prevalent, obviously, in private practice. So I have 27 residents just for IR right now, and soon to be 36. When they get jobs after they graduate, and I would like to be, I'm not bragging, but I think we do a great comprehensive IR clinical specialty research. They're in clinics, they're in procedures, they're in wound care. Then they get a job that's usually offered as only like 70% IR, 30% diagnostic. There's very few pure 100% enough for everybody that we train. So they go to that practice, they sign this contract, whatever, and they're promised 70%. You won't have to read from the imaging if you're not doing something. And then it changes because the reimbursement went down on something. Now everybody's got to pitch in more. And then there's bad feelings because all the diagnostic guys are like, why are we doing this work and we're pulling this in? And he's not saying what I started with earlier. The duality with the way the payments and the reimbursement is and what you're valued at is not the same. So as long as groups and hospitals say you're only worth what your professional income is, not what you're bringing to the system, this is not going to be tenable. So that's why hospital radiology groups and departments have exclusivity within hospitals. So an independent IR can't come in and start doing cases. Now, in hospitals, a surgeon, if they bring in outpatient volume, hospitals will grant them privileges usually.
Yeah.
Almost universally until more recently, radiology groups and departments will not allow anybody that's not under them and that they didn't privilege. They have an exclusivity, which has been the biggest bane of private practice IRs. Now what's happening is, I feel like from what I hear talking to people, the abundance of imaging that diagnostic can't keep up with, they're struggling. Some radiology groups are like, you guys go do your own thing. Or others are saying, we can't have you do any more procedures. You have to be doing diagnostics. So it's becoming this weird change where there are more private contracts slowly opening up and small and private IR groups. There's one in Chicago that's big. That's awesome. Good friends of ours. They've developed 13, 14 contracts with hospitals now. So they've created their own IR only system. So that what you're asking about, can you do both? You probably could, but it'll never be reimbursed the same in the mind of who's making the money. And also, you're not functioning the same, so why should you? Clinical practice for surgery and procedures is something you have to spend day and night working on. If you have to spend your day and night also keeping up with the new MRI technology and seeing chest micronodules, that's not going to be what you can kind of really build. It takes a lifetime to still build your own clinical practice. So if you're spending it with something else, I just don't see how both can exist perfectly.
Do people going into this radiology and interventional radiology understand any of this?
The ones who are in medical school coming into integrated have a better understanding now. Historically, we did not. Just because you still are primarily known as the interventional radiologist who can do procedures, who's radiologists who read images for you, but also can do procedures. But the time it takes with the diseases we're treating, the risks that you take on nowadays when you don't see a patient and you do a complex procedure, those are all not appropriate. That's just not how it works. Right? We shouldn't be doing, a complex iliocable reconstruction and you never saw the patient until you were already scrubbed.
Yeah.
But that's how historically it was. Like you said, you put an order in because that's a system. The person just goes to the Rex, goes go. Patient's on the table. All right, doc, we're ready for your port.
Why
You
am I
never got a
putting
chance.
it? What's
No
the
thoracic surgeon
indication?
would put in a port without seeing the patient in clinic.
Yeah.
Right? But everyone else is expected to because you're a service line, which is why the last decade and a half has been, we need to change that image. We need to make it a consult service. So you have to consult IR, tell them just like any other service. So you did your due diligence for the patient's safety and for what you're doing. And it may not be the right case because you run into a complication because you didn't work up that patient. So those are things, but that can't exist when there's 82 CT scans and no one's read yet. One of my friends at one of the major hospitals in the East Coast, he's a great IR, but he's in charge of all of it. He said they have MRIs that are 3 months sitting there not read.
Well,
So, like they're already struggling to keep up. So if you have somebody who's dual trained, they're going to say, we need you over here, which takes away from my clinical practice. So this is the dual existence is tough.
So what do you think makes the new generations tick? Like, what is it about IR that you think pulls them in, given that there's all of these complexities and that they don't, for example, choose vascular surgery or cardiology? Like, what as of now is your sense of what gravitates them towards the specialty?
I think the visibility of with technology IR, and there's been a push to kind of really expose medical students to it, to understand what it is and spending more time because more do have a clinical practice or they're trying to. And part of the integrated residency is that you have to have a clinical practice in your training program. So by them hearing about it more through social media, through commentary, even in TV shows, and then they start shadowing a little bit. It's not in the core medical school curriculum, but there's not a given week that I don't get messages from med students from our hospital or other hospitals saying, hey, I'd love to come shadow. That's not something we used to ever hear. Never. It's like when I was a med student, I wanted to do ortho, I would have to cold call random physicians saying, can I come just watch you do something today? Now I'm getting those messages to us, which tells me that the word of what we're doing and the future of what we're doing is exciting and unknown, but this is what we're doing and come check us out. That has definitely improved in the last 5 to 10 years. And it's been a push of everybody kind of putting your stuff out there, trying to be more engaging, be more interactive, step out of the dark rooms. That has been the change that we've all tried to focus on. Now, it's not universal, but by and large, we've had great matches for the last 5-6 matches in a row everywhere nationally for integrated residencies. There's a lot of learning curves, a lot of things to fix, and I think part of that's a dual nature. But med students are understanding that, yeah, they have to get through both to do their IR, and that's, I think, one of the things we have to work on is 6 years is a long time when you need to do just IR, but this is the only way we can get that transition. So I hope in the next decade of what I see is going to be a complete IR separation.
How much time do you think someone needs to be trained to be an interventional radiologist?
My best guess would be 3 years, because here's the
That's
thing.
That's really enticing.
What I would say, because here's the thing, even within IR now, we have subspecialization, and that's the future, I think, of what many of us hope to. We hope that in the future we have IR integrated, or IR residency, and then you're going to do a fellowship in something special. So, because we have components, we have interventional oncology. So there's people doing, one of the great guys at Northwestern, he's doing Y90, which is what we use for livers, in glioblastoma in the brain. Like, this is new frontiers where we can offer things that traditionally are different. We're just learning, but IO is a separate entity that we need to house separately. MSK pain, a separate entity. Women's health, men's health, and then PAD and venous. Like, these are all things that I think if you spend 3 years doing the majority of everything and then you specialize, instead of 6 years to get dual DRIR, you become a specialized IR. It's like a general surgery going to vascular surgery, you know?
But thinking about the future, and like we talked about this, and I talked jokingly about it, but I think it's completely true. Like if I had a med student right now that told me I want to be a radiologist, I would tell him you're crazy.
The general radio, yeah.
Yeah, general radiologist, don't do it. Like, really, like you won't have a job in 15 years.
I'm really curious how that plays out.
So that's my interpretation of what's going on. So I think,
Sorry, why is it that you think that there's going to be no radiologists?
because right now we have a software in our hospital that identifies PEs faster than a human right today.
So let's say in this,
Then who takes the ultimate responsibility?
that's exactly what I was going to ask you. Yeah.
I think that as
You got to blame someone.
Who gives it? That's not the problem.
no, but that's going to be an important part of this, because here's the deal.
the hospital
The
probably.
insurance companies, the malpractice insurance world, ultimately somebody needs to sign off on things because there has to be an ultimate responsible for that. I obviously think that the more palatable way to look at this is that you're going to make a radiologist a super radiologist, right? He's not going to be like, there shouldn't be 3 months of MRIs waiting somewhere, because now you're going to grab this AI machine. It's going to go through it. And it's going to say, hey, there's 10% of these that need your attention. The other 90 you should sign off of and be fine with it. And that 10%, I'm going to show you why. And then as a radiologist, you can add your expertise and the depth of your knowledge to say, well, here, or here's something else, and maybe get there. Are we going to get to a point where that's going to go away?
Yeah.
I mean,
That'd be
of
interesting
course,
if it goes that bad.
possibly,
Of course.
possibly, but then that means that also doctors are going to go away,
Of
right?
course,
There's just
yeah.
going to be robots doing surgery. And
Is
so on
that
and
is
so
that
forth.
the real future?
I think so. Yeah.
I think, so I think which ones is going first? This is my theory. There's only going to be 2 types of surgeons in like 50 years. One is going to be trauma, because the chaos of the like a heavy trauma unit might be difficult to navigate by robots. I may be wrong.
Like non-elective surgery overall.
The other one is going to be plastic surgeons, because it's going to be cool to be operated on by a human than to get like the standard, Amazon nose job that the Amazon surgeon is going to give you. So that is my theory on it. So the thing is, like, I would say to a medical student, if you want to be a general practitioner or a radiologist, go do something else. Go literally, like, I don't know, man. I would not go into those fields.
Could it be that AI can help the ones that need the most? Like internal primary care needs the most help.
Yeah.
They can't keep up with what they have because of regulation, because of technology. But they would be the most benefited by this, which then allows them to spend more time taking care of patients. Maybe that's an alternative way of looking at it, where radiology can deal with the bread and butter by AI, but there may be a clinical aspect in a tumor board and in a complex scenario where you need the specialist to help put that together. Now, could AI do that? I'm not smart enough to know if AI could. I guess ChatGPT can design a vacation for me, so maybe it'll get there at some point.
I think like identifying diagnoses, like if your job is mostly just to identify diagnosis and go by a guideline, you're gonna be out of a job.
So pathology can also.
Pathology is gonna be gone.
Wow.
Like gone. So I think, I don't know.
You should give a commencement speech at medical schools.
Yeah. there's a pathology resident graduating like tomorrow. That's gonna be like, fuck. Yeah.
You'll be on the podium. You're like, if you're in pathology, raise your hand.
Raise your hands.
And then like the guys will say, you all go.
I need a podcast producer. Which one of you wants
You
to
all
be my
go
podcast
drive some
producer?
Ubers right
Yeah.
now.
No, but like, so to my point is that I think all radiologists at some point in that transition, when the robots take away everything, are going to be just interventional radiologists. Because I think the diagnosis part is going to go away, and the ones that are going to be left, still drawing the shore, are going to be the people doing something with their hands.
I wonder if, but could this help? Because I think all three of our specialties in vascular care have the same dilemma, which is there's not enough. Even though it seems like there's not enough, it's a red ocean, but that's because our focus is not externally from your working environment. It's always internal. Those battles and it's because you have everybody fighting for the 5 consults when there's 27 next to you that no one's helping. So would that AI doing that alleviate and help more vascular surgeons, cardiologists, IRs figure out ways to spend more time helping others? Could that be a potential benefit instead of a fear?
For sure. I think for sure it's going to help us be leaner in operations and then be able to spend more time operating.
But to your point, you started by talking about the board. This is a problem with all 3 specialties. They all have the same problem where everyone wants individuality but has not been granted that yet. And the question is, why is it? What are the roadblocks to not get that approval? What's the process that says, I know you can't? You think it's the generational thing that people are making decisions aren't on the same page as you?
Multifactorial. Right now, you're not an independent board, correct?
Not yet.
I hope we were. But you've been able to build your own department, Del, in the hospital, right?
Yeah, we just became a department.
Maybe that could be an interesting story about what it took for you to be able to separate yourself from radiology, and how painful was that? You want to bring me back to?
I mean,
was that disparity when it came to billings and collections, the big fracturing point that then led to the, we're different conceptually, intellectually, philosophically, the way that we care for it's just very different. But the money was the fraction, the money was the big bang that ultimately led us to having to have independent boards. And how did you maneuver that in a hospital?
Yeah, I think all this is predicated on having a great small team. Fortunate enough that when I finished training and at the end of my training, my senior partner came in. We were a private group at the time when I finished training, so part of a private group, radiology group. And so have a great senior partner came in, and he had the vision of the same mentality, like we're always fighting to build something, but we get roadblocked by our own primary specialty. Not roadblock in a negative way, and I train in radiology. I'm very close to a lot of radiologists. It's just the way things are done and thought of and planned is not with the clinical IR's interest in mind. So we started building with a small group of a few of us, 5 of us, and we ran very lean for many years trying to build, and then we had to become hospital employed because that was the decision tree that the hospitals want, which happens everywhere. But in that process, we noticed that what we're doing, we're killing ourselves to build an incredible service, always available, seeing patients in clinic as much as we can between cases. But we're like, we need more support. We need more support. It's like, well, why aren't you getting support? Well, your chair has to push it this way. They have to fight. But then why would they when they got their own radiology things to worry about? So over the course of, it took about 10 years of work, and it's masterminded by my partner and us being on the same page, saying, if you want us to continue to build something, which we're building something great, we built a lot of clinical trials, we're doing a lot of services, we're bringing in all these patients. It's understanding, we're never told as physicians what you're bringing in a hospital system. You're learning all that, and you guys are, because you got the private practice, you're building your own. But ask any physician in a hospital setting, how much did you bring in from outside hospital?
They won't tell you.
They won't tell you, and it's hard to get that information.
Yeah.
So you have to spend a lot of time doing your own data analysis, try to figure that stuff out, say, wait a second, every splenic embolism, every leg case, this is what I brought in, and they weren't part of our system. Now we can do more of this and bring more, which hospitals love, but we need the support. And the only way to get support is help us be separate so we can function separately. We can understand our economics. We can ask for things that are for us. So it was a multi-step process with good support from the hospital, but just have to go through all the process. And as of last October, we became an official department. Now, historically, Daughter Institute in Oregon was one of them for years ago. Daughter was obviously there. But really outside of that, University of Miami became a department a few years back. I think we're the kind of third, but now all of a sudden we're seeing a little bit of a domino effect. Kaiser LA, Joji, fantastic guy. He just became a department. And a lot of smaller ones are actually having those conversations because hospitals and others are starting to learn more and hear more from other people who've done it and say, wait a second, maybe we can make, at the end of the day, hospitals like, how do we make more money? Because that's what they have to do to support everything. If we just understand the language of how you're bringing more money and what you need for it, then suddenly the discussions can start being had. And with radiology overwhelmed with a shortage of radiologists, overabundance, every hospital's opening 10 imaging centers, like they can't keep up. So sometimes they're like, we can't keep up with the stress of this. Maybe you do your own thing. And I think that's opening up the doors. So what some of us took a lot of effort to build and do and kind of grow, others are starting to learn. So I think that's helping the process. But by and large, it's not everywhere. And like we talked about contracts and this and that, it's still an impediment. But at least the knowledge is getting there and more people are talking about it. Same thing for you guys. You need a groundswell of people who want that same separation, whether it works or not, I don't know.
So I've noticed also in the last few years that, I mean, the outpatient models of care are sustainable. I would say that the margins are there. This is coming from my own personal story, right? I was in the hospital system, working for hospitals. I left that. I built something on the outpatient side, and I realized lots of work for sure. I would even say I work more now than I worked before. It's different work. But the margin is there, and you can pay the bills and you can have a good life. Do you believe that that's also going to be something that we see as a novel, sustainable pathway for IR to be strengthened by some of these outpatient models? Because the inpatient problem is that, to your point initially in this conversation, is those procedures just don't pay a lot. And we can see that the system is out migrating, right? I mean, every part of our specialty, and maybe that could be something interesting to get back to, like, where's the future of your department? If a minimally invasive department, it should be outpatient and not inpatient, how do you maneuver that? But it seems like that outpatient outlet that just recently we got, for the first time in history, some good news that some of the codes are going to be better paid, that there's going to be complexity expanders. So now there's modifiers. So there seems like those that have an outpatient facility are looking at a 2026 where maybe there's going to be a little bit more margin that's going to give oxygen to the system. And that's going to continue, right? ASCs are strengthening themselves, and I believe it's cheaper care. It's probably primarily fueled by the insurance companies also that want that care out migrated from hospitals, where the hospital take a higher technical component. So maybe frame what do you think IR in the setting of these novel outpatient facilities that seem by all means are going to keep growing, and then maybe come back to what do you think about the future of IR in hospital settings?
I mean, I think you need both. But I do think we don't have enough of that outpatient, independently owned or, independently profitable systems yet. We have a lot of IRs who are young and some older who've went that route now and are increasingly going that route. So I think it's only going to strengthen that. And it's actually, you've probably seen it, many of them are joining other specialty practices together, they're banding together because there's this underlying notion, you probably see it on social media, like doctors have to take back healthcare, have to take back hospitals. It probably won't happen in the hospitals.
Mm-mm.
I don't think.
No.
I think that's just like you're throwing water in the air. But I think the independent private practice, OBL, ASC group combined. Now you build another. I think that's the path forward for all of our specialties to get some kind of control back. Now you're also seeing private equity buying those out, and now you become an employee of the private equity.
Yes.
So that's the danger of doing something too good too, because right away money is the driver of everything, right? So you spend 10 years building OBL and then you get bought out, but then you got a 5-year contract, you have to work for them. So those are things that kind of have to navigate, but I only see it as a positive when IRs can finally go do what they want to do without being under the pressure of somebody else, another specialty, another service. But you do need the inpatient or hospital service. Where are you going to train all these residents in a safe environment? That's where we have to train these people, right? Now, can you incorporate the outpatient? I think that's 100% what we have to do. We have to get trainees into that world because I can't teach them the OBL world or the ASC world. As that grows more and more, we need those centers to be somehow associated with the education so that the trainees come out and make better decisions and have a better outcome and a better outlook. So I think you need both because in your OBL and your ASC, there's still things that you will not do. So you need the hospital setting and places to innovate, to come up with ways to handle complex things. So you should never have to give that away. You just have to adjust where you do it and how much your time spent and is there another opportunity. So instead of my backup plan being radiology, my backup plan should be when I'm done with academics, go to private practice. Because there's a robust thing there for me to now build my own on my own. And I've done enough of training people and this and that as a primary work. So I think we need that as a plan B, not in our space. We need that, but I don't think you should get rid of one. It just may help us feel better about having control and building the way we want.
What's a win in your mind? What's a win-win scenario for the relationship between independent physician and a hospital? Like, could you see that even possible right now for you?
A win-win between the hospital?
Relationship, yeah. Like, what does that relationship look like?
Like a private practice physician.
Yeah, so you're in
Well,
the
I have absolutely no doubt that I'm a win-win.
yeah.
I
But do you feel like a win-win all the time when you're in the
Do you mean like
yeah.
what do you mean by that? Interactions?
well, I'll
or-
put it in this term. I'll put it in those terms. I was working at Methodist, and then one day I wasn't, at least not for them, but I kept my privileges. And I went from not knowing who anybody in the support area were to now having a valet VIP card entrance to the hospital.
Are they hiring?
And, and no, but that's the thing is like, I didn't get it when I worked for them.
Oh, interesting.
So what I was trying to say is when you are a valuable private physician that owns those patients, most hospitals that are for profit are going to be very interested in having you there and making you happy. I think that where I think they struggle to is what doesn't necessarily cost us an investment because we have no control over him. So that's what really irks them, which is now they're going to give me things like, okay, we'll work your patients in, or we'll, give you access to hospitalists. We'll give you a valet card so that you can come. We may even go and give you an Epic account, which is part of what they offered in their package deal so that I didn't have to pay for my EMR. But but then what happens is at the end of the day, if I get pissed, I just go to HCA and I take my cases there, and that can happen overnight. So the thing is, do they want to really give me a service line agreement? Do they want to give me a directorship? Do they want to give me a nurse practitioner? Do they want to help me recruit another doctor? Like whatever those things are, I think that they are much more frugal, and they would prefer to own you before they invest in you. Now once you work for them, then they'll add marketing money. They'll add other things that you bring to the table to make you, because now it's a much safer return on investment. But I do think that there's a position of value that you can get yourself into as a private physician where you're essentially saying, okay, well, I've got options. You make it the best for me, the best experience for my patient. I'll bring my patients here.
Yeah.
There's just not a lot of us.
You reverse engineered your life because you got more perks from being outside of the system.
And that makes sense because you value. So how do humans assign value to things? So, when you're an independent entity to be in relationship with you, then you have to kind of give to receive. When you own something and it's just like an item on a balance sheet, you care less for it. So I think it comes down to kind of human relations to it.
That's why I like smaller hospitals. I mean, if you ask me today between Methodist and HCA right now, I do most of it stuff at Methodist, but I feel that I would get probably more personalized love, TLC. If I go to a smaller hospital where they're going to know who I am, where they're going to know me, there's only another surgeon. There's not 8 other surgeons, right? I'm not fighting for all, if I don't have to do my cases at 10 p.m. I could do them at 8 a.m. And those are the perks that ultimately make.
Kind of like a guest in your house.
Mm-hmm.
You make the house perfect. You get everything nice for a guest, and then you go back to regular when you live there, right? It's kind of what you see in this world. Like, you're bringing in value to them because you're bringing in patients and revenue, and that's what the enticement is, to make you happy, right? But when you were there, the same enticements weren't there to make you happy.
Exactly.
It was, we need you to produce more on your own. Figure it out.
So as an interventional department, does that mean you also get like CT guided biopsies that falls under you? Do you get
So it depends. A lot of
IO?
practices
get
are
all
different in the
this?
country. Many IRs do all the biopsies and all that stuff as well. In some places, there's body radiologists who will do, CTs, MRIs, but also do the biopsies. In our place, we still do majority of all the biopsies, abscesses, line placements, but we do a lot. Our outpatient practice is primarily, everyone has their own interests of interventional oncology, PAD, venous, men's and women's health, MSK. So you actually do both. So we'll have an elective room, we'll have an inpatient room, and whatever. So there's common stuff that everyone can do, and then you have your own scheduled electives that you brought from clinic into your room. So there's kind of a dual thing there. Now, some people say in the future you should have a hospitalist IR, meaning somebody whose job is just to do
Lines
abscess, drains, biopsies, inpatient stuff, and then everybody else can do whatever they specialize in, kind of like what you see in.
sounds horrible.
Like, for that patient in the hospital, like, you're their savior, right? So whatever small it is. So it's like, I try to tell residents, like, whatever you're doing, big or small, just remember, like, what you think is mundane in a simple case, that person's like scared as hell. Even if it's small to you, it's small to them, it's life-changing.
Yeah.
PICC line sounds crazy to be big, but there's enough patients that are fearful as hell for, they don't know they don't, even though you told them, they don't know, they said, you're going to put that in my heart. And for you, it's a 30-second procedure. But for them, they're telling their family members, I hope I come out of this. It's just a way, because we have to always remember that how big or small, it's life-changing for them. So I try to tell residents, it sounds terrible to do all the inpatient stuff, but man, you're helping these patients without open surgery and delays and all these stuff, get out of the hospital, back to their families and stuff. So it's not something I feel we should ever be bad about or give up. It's critically important for them. But what do I want to do day to day? It's my outpatient elective stuff.
Yeah. Yeah.
How I wonder about the complexities of now. Finally, by the way, kudos to you and your partners for being able to build transformative change in the hospital as a department. But now, what happens if I'm just trying to steelman this from the other side of, now I'm a hospital administration. Now I agreed to make these psychos their own. I gave them
this guy Kumar.
yeah.
Did you talk to them?
I gave this sociopath his own department, but then I also have a department of vascular surgery, and I also have a department of oncologists, medical oncologists that now have these interventional fellowships and are also doing some procedures. So then, as an entity, where do I invest for growth, right? Because do I go and publicize, send your patients to us, we have PAD experts, and then if somebody calls and says, I want to come because I know that you are experts, well, where does that consult go? Is it going to go to vascular surgery, or is it go to the interventional radiologists? Because you're now creating confusion within the system that, by the way, remember, hospital administrators are usually the C-level people in business school, right? Nobody that's really, really good at business goes into hospital administration, healthcare administration. It's just the dumbasses. I ask anybody in business. Nobody that was a student goes into being like, oh, I want to be a hospital administrator. No, those are usually the lower people on the intellectual pole. You have an issue with that? Come and debate me. Come here. Come on the show. This is open for any of you hospital administrators. You think you're super smart? I want to see your scores. Show me your college scores. Show me you're an A student and that you chose purposely to go and fuck with us in the hospital. Anyway, how do they allocate?
We're working on it. That is my mission, to like help him process his trauma. He gives me shit about it, but yeah.
How do we allocate investment of $1 when now I'm diluting in different departments? What's your thought?
I think that's a great question that doesn't have an easy answer. But what I will say is that if you if you are a strong team, a department, your job is also in your whatever levels of leadership is to, unfortunately, fight for what you need and what you see as the future. So
Or fortunately, no?
yeah, I think it's for us. I think
Fortunately, you
fortunately,
have to fight.
we finally have a seat at the table. We have the opportunity to finally be recognized and be relevant in the C-suite as a department. So I think you have to figure out how it is that you're going to get what you need or get what you think. And I think the problem is in societies and our hospitals, we are forced to just fight, which is ridiculous because when you went to med school, you did not understand this. You weren't told that, hey, in the future, you're going to have to sit there and stress out about how to get more patients, even though your salary is the same. You have to get more this. You have to be more efficient. You have to finish your charts. You have to do all this. Otherwise, you won't get, it's wagging the carrot, right?
Yeah.
That's not what we were told in medical school. Then we go and 10, 20 years later, you're in the system. So I think if we step back and say, all right, how can we make improvements to reduce my stress and get what we want? You find the people in your team, in your other services that hopefully you can open the bridge and say, hey, what can we do to bring more money for all of us together? How can we approach this and bring a package to the C-suite and say, maybe we can combine our efforts. It's not everybody in your department is doing this, everybody's not doing this, but the few that do, let's come and say we need these things collectively. It's not easy, but they do it in oncology where they have joint clinics and joint services. In a lot of IRs, they have joint fibroid clinics with OB-GYN. We're developing ones with urology for prostates. So in arterial, it's the same thing. If you find some like-minded people and just work together and figure it out, you have to show them that the overall goal is for all of us to eat better.
What do you think was the reason? What do you think was the basis of you convincing them to give you a department?
I think for us, it was that we had already made a strong presence of care, of being available, of building, and a need by everybody to have us do something to get their patients better, and knowing that value, knowing what we bring in, and telling them, hey, we know what we're bringing in, we know what we're doing, but we need more support to grow this.
So
It's
you
not
essentially
like a
you
threat.
essentially worked your ass off to a department.
We worked our ass off, I think, because we inherently were a group of people who worked their ass off, and we like each other, which is rare in medicine. We actually all like each other still to this day after, and now we've grown. Now
you don't like each other.
no, I'm saying like, we actually like each other a lot more because we have more time, but we've grown in number because we ran lean for so long to build it, not for any other purpose other than quality control's hard when you're too big. And if you have enough to do or you're overworked, you have enough to do and you can build. So now we went from, 5 or 6, now we're going up to 9, but carefully. It's like curated because we don't need anybody that doesn't follow our mindset. Now we're a little bit unique in that, but that's the only way I see you grow, you build, you sustain quality. You guys will probably see it. It's like you never know who you'll get. You never know what. It's not a fault on anybody, but that dynamic has to be maintained. That level of excellence where I know that any one of us gets a call about something, we'll all talk to each other and manage it probably the same way. So I think the thing was we built a reputation and a service and a level of these guys are always here, not because we don't like our lives or families, just how I think we're built individually, and some of us trained there. We stayed there and we built it. So I think it helped because we were always available. We're always the things that people talk about, the 3 A's and all that. It wasn't like we taught each other that. It was just led by example and we all do it together.
What
So
are the 3 A's?
it's like affable, available, accountable, not asshole.
I think those are my
A
3
true
A's.
presence in the hospital for anybody to always know that, hey, you got something you need, you're worried about something, you need help, we'll help you.
My 3 A's are anarchy, alcohol, assholeness.
Yeah, that sounds about right.
Thank you.
That aligns. Yeah.
Thank you. I think you're gonna have to outcompete all these people. I think so. I mean, so here's what I would do. Again, I going back to my comment before is I think the hospital administrators are imbeciles. I think that you're gonna outperform every one of them in every department you can, and so that here's my advice for you that you haven't asked for. I think I think you sit down and you overly negotiate as much as you can every single year for your department, blood and sweat, fuck it. Like, I don't think that you need to necessarily go to work. You keep relationships and collegial, but I think that you need to say, I don't want your marketing. I'll do my marketing. I don't want your, I'll do, take over as much as you can internally and then use that. So instead of just fighting for pennies to hire some good guys that you like, fight for more pennies to do more on your own and then go and make that business yours and then outperform, outwork every single other division that potentially has something on you to the point that you then just crush them?
I would say whatever you're doing is working. Yeah, whatever I would say, whatever you're doing is working.
I think
And
we have
Well, but the problem is he was fighting to get to this
yeah,
point,
and he did a
and
great
now he
job.
got to this point, but now it's sustainability. Because again, in a year, the new CEO, because how many fucking times do CEOs in hospitals change? It's like they change, like changing. How many
No,
times has
of
the
course.
leadership in your hospital has changed since you've been there? I would say every single year at Baylor, there was a different hospital leadership. Every single year they change. And every year we ran in a different direction. Oh, we're going to build a new hospital. Oh, we're not going to do a hospital. Oh, we're going to relocate clinics. Oh, we're going to get a new patient. And we're going to open clinics. Well, no. We're going to hire 3 vascular surgeons. We're going to hire 0 vascular surgeons. There was never any consensus and any direction. So all I'm saying is if I got to the point where Kumar is right now, is I would fight for absolute control and try to internalize as much as I can and make my division become a monster division, a monster
I
department.
think one thing is that there's an underlying problem in medicine where people stay where they're unhappy too long. And I think you have to hopefully find ways to find happiness, because we kill ourselves and spend and sacrifice everybody in our life for this. But I don't know if we need to. I tell my trainees, and whether they listen to it or not, I say, you're going to go to a job and you can't predict how good or bad it is. You're going to go there and hopefully just grind and build. And if one day you wake up and you're not excited to go to work, get out. It's easy to say that to people, but you've done it. You left, right? And changes in people's life. Like, I think we have to remind ourselves and our colleagues and everybody, hey man, if you're miserable, don't keep that misery there. It's only going to affect your family, your life, and your mental health. Get out and find another job.
And to that's why I kind of disagree with this like win-lose, red-black philosophy. I think the only way to be happy is when everyone around you is winning. That's the only way to be happy. I just don't think you're like I want to be happy. That's my number one fucking goal. So do I have more money, less power, more power, less power? I just want to be happy. So, and I think the way to achieve that is by like everyone that's in my life, everyone that's in my organization, everyone that's around me wins. But I don't know if that's true.
But there's a lot of
I
that
don't
in
know
what
if
you're
that's true,
saying,
but
though. You have to be happy in the wins you're getting from battling, you say. But if you go in there saying it's a war between us and them, it's probably going to stress you out to an extreme, because you're never going to get what you want in a hospital system. There's too many layers of, money, support,
C- students, yes.
whatever it is, where it's not going to be, here's my package, take it or leave it, because then you're doing like a threat, whatever, which is fine. But maybe if it's not,
that's a way to operate.
maybe get out.
Yeah.
You get your a lamb wool and you walk like this. You go to the meetings and you play the part and you're politically correct. I'm not saying to go burn the ground, but I think you fought to get to where you are, and now you have to fight to stay where you are.
I agree. I think that's 100% accurate.
Because people are going to be like, okay, motherfucker, you can beep this out, but you wanted to be
We're not
here,
bleeping
here
anything
you
out,
are.
yeah.
I mean, if I was the CEO, I'd be like, okay, brother, I mean, you've been doing 10 years, you've been fighting me. I'd be like, here you go, done. You have your own department. And then in a year, I'd be like, okay, show me what you've made. That's what I would
Do you
do.
find happiness, and happiness could be people that you work with that, aren't malignant and you're fine with. You have an opportunity to grow together, and as long as that force is there, you're going to keep finding opportunities. And when you find opportunities, you demonstrate those opportunities in a financial way to whoever.
Do you have a good business person?
Not a good business person. We have a great group of faculty, and then we have
Like, is there a numbers person in the department that when it comes to, it's you?
That's our senior part. Yeah, I think you have to learn, and we're all learning too together, is how to understand your value and negotiate. I don't think you can hire a business person, but that's more in a private practice model. If you try to get a business person in your hospital environment, that's going to be a little weird. It's going to be tough. You'll have administrators who are, part of your department that you need to seek those numbers and questions and figure out. Like you talked about the new codes for complex things. That's fantastic. That's not something that's usually trickled down to us in the hospital setting, but I know that. So we're going to start looking at how do we make sure we're building that way. Because when I do all these things, are you guys recognizing my value and getting that value back? And that's not something in a hospital setting you're usually taught. So I think we as physicians have to understand this, even in a hospital setting, and get those numbers and seek those numbers and try to figure out where can we get more of our value for the time put in. Yeah, it'd be nice to have someone else do it, but who else can you trust but yourself?
We're saying the same thing.
Isn't that funny? It's a circular thing that came back to.
I mean, the amount of money that stays on the table in the hospitals is ridiculous. The amount of bad debt, the amount of money that doesn't get collected from administrative problems, from bad coding, from all. So you have to really, really get into the weeds of making your department as efficient as possible by trying to get control over as many of these parts of the process. If you don't have a good denial management person, 20% of your claims are going to go unpaid. That is a lot of money to sit on. And so when you are now leading the way, that's the sort of stuff that now I came out and I'm out. If I ever go into a system back in, God help me, it's going to be ugly. You think it was ugly?
The show.
You think? Let me make sure right now that nobody ever hires me by saying,
you're doing a great job.
You set the tone.
You're doing
God
a great
help
job.
you.
Yeah.
If you ever offer me a job, God help you.
But I
Get
think
ready.
that's where our point was about needing both private practice, but I think it needs to be integrated into, your system.
Yeah.
We're nowhere near that yet, but I think that's the only way where you understand both sides within the same system. I don't know when that's going to be, but I think we keep pushing the narrative and we keep talking together about it.
What was the sign of anarchy? Is like this, right? It's like anarchy. Bring the systems down. Let's refurbish healthcare. Let's make it appropriate and easy, and let people get what they need. And let's not fucking fake it and make it so impossible that this healthcare is fucked up. And when we talk about these things, it just shows how unfortunate this is. It's all a house of cards.
Yeah.
And it's gonna fall. There's no way we can continue being what we are right now. This healthcare system is not. Anyway, what a positive way to finish this.
Positive way.
Yeah, I was really excited this week.
Sunshine, rainbows, unicorns here at the Life of Flow podcast. All right. So I think we wrap things up, guys, in that positive note. Thank you. I hope you come again.
No, man, this is the only way we talk. This is therapy, right? This is
Literally.
mostly for
therapy,
Miguel, but this is.
Yeah, we're working. He's better.
Kumar,
Dude,
you can hire me as an advisor of the department.
Yeah, sure.
I'm gonna come in.
Yeah, fucking.
I'm gonna do some team building
flamethrower
stuff. It's
with
gonna
a
be
with
super
a
good.
flamethrower in hand, just like
I wonder if Hope Vasquez has a spot for me. That might be the last.
Yeah, exactly.
Come, brother, we got you.
That's the strategy. That's the strategy. Get you fired
You
for
get
being
equity.
here, and then
You get equity. We got some equity for you, bro. Okay.
Oh my God! No, it's been great, man.
Hi, everybody out there. Thank you very much for paying attention to the Three Stooges this morning. We will have you soon again.
What do we do?
Hopefully, you don't get fired.
Oh, is this live?
Ah.